Hi, good evening to everyone. Thank you for joining me. I'm Dr. Philip McMillan, a physician in the United Kingdom, and I've been following COVID for over 6 years. I've interviewed loads of experts, and I have gotten the insight that I've been sharing with many people over the years. Today is again a Dr. Shankara Chetty Day. It's very special whenever I get a chance to talk to him. He has so much knowledge, so much clinical experience, and as we all know how well he did early in the pandemic, he continues to help people across the world. Important point. What I want you to do, because many times this kind of video is not getting in front of the people who need to watch it. Please remember, like, share, comment. I will always try my best to share comments, especially telling us where you are in the world. That way, it helps people to understand that this is a global community working together to find solutions. So, without further ado, let's get straight in and add Dr. Shetty. Hi, Shankara. How are you doing today?
Hi, Philip. I'm doing fine. Hello to all the people in the audience. Good evening to everyone.
Not to worry, Shankar. I'll tell you what you do. Just give us again a quick introduction so people know who you are and where you are from.
I'm Dr. Shankara Chetty. I'm a natural science biologist and a general medical practitioner. I reside in Port Edward, South Africa, a little rural town, and I'm a general family practitioner here in South Africa. During the COVID pandemic, I took the time to observe patients using my biologic science understanding to get an understanding of the pathophysiology, formulate a treatment strategy, and understand why we had that kind of illness. Of course, that led me to be controversial with the vaccines and speaking out against them because I found that the primary pathogen was a protein that the vaccine was going to make in your body, spike protein. And so, yes, I've been part of the team driving the understanding of the pathophysiology and the treatment around COVID itself.
Excellent, Shankar. So let's get into a few things before we start. I mean, they had this court case again, trying. I mean, it's quite remarkable. They're technically trying to de-license you for saving lives because you didn't do it according to how they said you shouldn't save lives. So in effect, they are upset that you tried to help patients, you actually saved patients, and they are saying you shouldn't have tried. Where are we with regards to that case?
Well, Philip, I've been charged with, I think, the entire extent of COVID, from the lockdowns to masking to speaking out against the vaccine to calling my work misinformation and misguided. But with the charges against me, I accepted the charges and asked them to present their case. And I've had nine of the world's best experts in every field, covering from the science to law to military intelligence, testifying in my case. They came forward and were willing to testify. So we're supposed to have started in March last year. I think they saw my witness testimonies and it scared them a little. It's supposed to have progressed in June last year. It was then postponed to May this year. The 4th of May should have been the start date. It was postponed for a year so that we'd have no further postponements. But I received a letter 2 weeks ago to say that it's postponed further to the 23rd of November this year. I wrote back to say, well, you're postponing it till after the start of the next pandemic. I think they don't want me to foil their plans. So, yeah, they must bring it on. I'm sure they'll have more charges against me the longer they wait.
Yeah, I mean that is fascinating in itself because everything, not everything. I guess I should just say be careful to say that so much of what you had predicted and said is turning out to be accurate. So bringing a case against you, as I said, and I think the problem is that you wanted it to be public so people would see the fact that I mean it's quite remarkable that we are having a situation where the people who had the best outcomes in the pandemic are the
Yeah.
people who are criticized and deplatformed the most. And I don't know how medicine will get around that in terms of the fact that we have to do better. I think that medicine now needs to become again the advocate for patients in order to try and find solutions. But what we want to talk about today, Shankar, is what you're seeing now. And I'm going to be combining it with some of the data that I've been collecting. And so just to show the audience what I'm looking at, I've got here, this is 186 million NHS admissions by age group, looking at the kind of conditions that they have. And as we talk through this, I think the most important thing is that you must know that whenever anyone tells you that things are the same, you need to take them to this kind of page. And the links are in the description. If we take 30 to 40, 4 years old, anything is red is an increase, and you can see all the conditions that are increasing in terms of hospital admissions. And it's important to note that these are hospital admissions. This is not the general public. And here is the thing that people don't get. If people have things like a migraine severe enough to cause them to be admitted to hospital, what does it mean in terms of the severity of symptoms broadly across the population? Because migraine, it must indicate that one across the population is just that a proportion are so severe that they need to be admitted to hospital. Any thoughts on that, Shankara?
Yeah, Philip, I think the hospital admissions are just a subset of what we're seeing, the most severe. But as a GP, seeing patients in an outpatient setting, I'm exactly what you're presenting there is what I'm seeing, and we're trying to resolve those issues. Unfortunately, a lot of those patients that end up in hospital have the specialist scratching their head, not understanding what's actually going on. So I think it's more widespread than the statistics actually allude to. There are many patients out there that are walking around unwell, but not unwell enough to be hospitalized, and are being inappropriately diagnosed and treated. And I think, yeah, the lack of understanding around pathophysiology and treatment strategy has led to the crisis we face.
One of the problems, Shankara, is that I think that there is a mislabeling of what we call long COVID. We've almost called it everything. Anything that's post pandemic is long COVID, no matter what it is. And it's so diluted that it no longer makes sense. And I think that we need to use different kinds of descriptions in order to try and help people to understand what really is happening to them in a logical way. How do you communicate what you have been observing with regards to post COVID? Do you still call it long COVID when you're talking to patients?
I guess, Philip, the mechanisms in both uh, long COVID and vaccine injury are pretty much the same if you exclude the contaminants, lipid nanoparticles, and messenger RNA. Spike protein is the most important culprit. So when I deal with this, that is the port of call, dealing with the immune response to spike protein, which is very individual, which affects many different systems, can be very unique with different patients. And so I start there. Whether it's post vaccine or whether it is after a COVID infection, that I work back on a timeline to see what triggered it. So I have vaccinated patients who have had no problem with the vaccine till they got a COVID infection. And I've had patients who had a severe COVID infection, developed prolonged symptoms, took a vaccine and it made no difference. Some the vaccine worsened it, some the vaccine actually seemed to benefit them. So there's this mix and match of a whole range of things. I think at the end of the day, Philip, we're dealing with an individual response, which is very unique to the individual. And so to understand the broad pathology that can manifest is vitally important. Every system in the body gets affected, every that can be targeted. And so you've got to be very vigilant of these kind of symptoms. We don't have the testing to clarify our diagnosis. So there's no test to confirm what you're thinking. At the end of the day, it is about questioning the patient, examining the patient, and looking at timelines. And if you can't find any other reason for things, then you got to look at it and say, well, it's spike protein and treat it as such. And Philip, with me doing that, I'd say 80 to 90% of my patients have an 80 to 90% recovery within a week to 2 weeks. So it's understanding the pathophysiology, looking at the systems, where it's manifesting in that patient, their history. Is there any injury? It tends to target organs predisposition. So if a patient has a subtle inflammation that they were unaware of, somewhere in the body, that tends to get targeted. So we're seeing reemergence of old symptoms, and I think that was the plan behind it, that it exacerbates your pre-existent conditions, and we'll blame it on that. But it's strange to suddenly see all these pre-existent chronic conditions suddenly worsening in patients that were well controlled.
I use an image to capture what I think has happened. And this is where a lot of people don't quite understand the point. But this is the image that I use. And in this, what you have is COVID infection or vaccination. That's the petrol. This here is a lighter. It doesn't matter what the prior immune activation is. If you spray petrol on that, you get an explosion of fire. Okay. And the problem is that if these are not addressed, these embers, they, in a sense, will always be at risk for this explosion. And
Yeah.
anybody who had this inflammatory ember can therefore get this kind of response on exposure to spike protein from any cause. Is that been kind of your experience?
Yes, yes, Philip. And what I see as well, Philip, the exposure to spike protein via the virus and the vaccine tends to be different in different patients. I've had patients take the vaccine with no problem, like I said, and have COVID and have a problem, and the opposite way around. Just an example, I had a patient who refused the vaccine. Uh, she's been fine, had COVID 3 times, got over it, no issues at all. She had a shoulder problem and as well, I think over time, history of anemia. When she went in for the operation for her shoulder, they looked at her anemia and transfused her while she was on the table. And she went through the shoulder op, no issues, came out of hospital, and within a few days of being discharged, started feeling very unwell. When she presented to me after, I think, 3 days of her discharge, had swelling feet, had palpitations, had a fluctuant blood pressure, and it looked like she had developed myocarditis. So I was wondering, how did you develop myocarditis? What was the? I looked at the anesthetic she was given, all the kind of things to see there was no side effect from that, and we're all well aware of that. And the one thing that struck me, she was transfused. And of course, the blood services are not looking at whether it was from a vaccinated or unvaccinated patient. So I'm suspicious that she was just exposed to the vaccine through a transfusion, and that triggered the myocarditis. And I think I'm actually making an appointment for her to see the cardiologist. But how would a patient that goes through a simple operation, get a transfusion, end up with myocarditis? Now, if you're not having that at the back of your head, you're never going to figure that trigger out.
Well, it is interesting because this was doing the rounds on social media recently. And it was about people refusing blood transfusions when they're unvaccinated. And I think my point was that there are already risks with a blood transfusion. So it's not as if blood transfusions don't have any risks. But if you are being given a blood transfusion, it is rarely, it usually is because you're going to need it. Either you're bleeding or there is going to be some significant thing that is occurring. And so, in the context of risks to spike protein or mRNA exposure in somebody who was vaccinated who donated blood, you have to wait against the risk of not getting the blood because of what you've had. What are your thoughts with regards to that blood transfusion issue?
I think the blood services, Philip, need to come to the party. I think the propaganda is extended to the blood services as well. There was a case in, I think it was in New Zealand. This is a few years back when the vaccines had been rolled out. And there was a child that was born that needed a heart operation. And I was called upon because the hospital itself refused that the parents donate blood for the child. That was allowed previously. You could have private donation. You could choose who you'd like to donate blood to you. Now, suddenly, when COVID came out and the vaccines were broadly distributed, suddenly the blood services made that service no more available. You had to just take whatever blood you got. And unfortunately, with that child, Philip, uh, the hospital brought in the police, pushed the parents aside, and actually did the operation on the child without the parents' consent. And they refused to tell the parents where they got the blood from. It was crazy. I mean, we've gotten to a point where We were fighting about informed consent. To take a newborn away from a parent and do a heart operation on a baby with a blood transfusion that's unsanctioned by the parents, I can't see how the medical fraternity can go down that road. And so, yeah, I think the right way to do this would be to allow patients to nominate who they'd like to donate. If someone would like to donate blood to me that's unvaccinated and I'm happy with that, why shouldn't that be allowed? There's no scientific reason for that not to happen. And especially if it's a family member, there is more concordance with the blood types and things like that. Less chance of reaction. Why did we make that illegal now? There's no scientific understanding behind that. Is it that you want to force this vaccination on even the unvaccinated through a blood transfusion? Because that's what seemed to have happened in the pandemic. We had no choice. It was mandated onto us. And it seems like even though the mandates have passed, what do we do? Another thing, Philip, what do we do with organ donation? Do you transplant an organ from a vaccinated patient into an unvaccinated patient? That's life threatening as well.
Well,
So
I guess the question would be, so this is now where, taking the objective view, let's just say organ transplantation. If you are lucky enough to have a match for a heart or a liver or a kidney, which is hard enough, and you are on the list and you are at the top of the list to get this done, and then you ask that question about, is a person vaccinated or unvaccinated, because that list of people is so long, you are likely to end up getting kicked off the list
yeah,
because of that question. My feeling is that there are certainly risks with regards to spike protein exposure when it comes to vaccinated cohorts and so on. But I am still not convinced that those risks are high enough that it would warrant somebody making the decision not to have either a procedure or a transfusion if they absolutely needed it. I mean, this is the challenge we face with Jehovah Witnesses who don't want to be transfused. What I don't like is when people make the judgment that because someone is concerned about it, that is irrational. I think that is absolutely wrong.
yeah,
If somebody has a concern and you haven't answered that concern, it's not irrational. You may say that in the context of the situation, they may be too focused on it, but this has never really properly been answered as to what are the risks. They've almost said it is so irrelevant that it is not worth looking at. I don't agree with that.
no. Philip, I think it is the people that provide these products are obligated to ensure its safety. And of course, if there is something that's affecting the safety of the product that you're providing, it be it blood or organ, it should be the onus should be on you to investigate and ensure that the product you're providing is safe. Now, yes, we can talk about the exposure to spike protein and the risks involved, the type of operation, weighing the risk benefits. But the problem is that spike protein has a very varied response in different people. So you can get someone with a very little bit of spike protein that can be highly toxic to them and trigger a myocardial event. And you can get people that can handle a lot of spike protein with no problem because it's their own immune response to the protein itself. So how do we determine who's going to react with the blood transfusion and who's not, separate from the overall risk of the procedure itself? So you might have a procedure that's really of no risk to the patient, but the transfusion poses a very high risk. And you can have someone going through a major procedure where the transfusion is vitally important to them, and there's no risk from it because they don't react to the spike protein. So it's very individual in their choice. And of course, until we get testing to see who's prone to develop these kind of reactions, what kind of cohorts are reacting, is there any genetic predisposition or blood type that might dictate what kind of reaction you have, we're never going to improve the safety of those kind of products.
I think that one of the problems we have is that there is a determination that some of these questions are too controversial to even try and answer. And therefore, the best approach has been by the scientific community is to ignore it and treat the people asking the question as being irrational, almost like I think the flat earth kind of cohort. It's such a crazy question that it's not even worth wasting time on it. And as I said, usually people who say that are basing their principles on ideology, not
Yeah.
actually a reflection of the science, because the science very clearly indicates that spike remnants are in people causing symptoms. It is in some people and doesn't cause symptoms. We don't understand the actual mechanism as to what the trigger is. Is it due to the characteristic of the individual, or is it because of some characteristic of the spike protein? And so I think, as I said, we should be investigating this. We should have a responsibility to look at it. And what I predict is going to happen in the future, I said this to a histopathologist recently. I was chatting to, and I was talking about autopsies and the fact that the autopsies are not being done. And I said we need to be aware that when there is an issue down the line that we can't get out of the way of, the powers that be are going to blame the scientific community for not investigating it, and it will still fall on their heads. And I have a feeling they are kind of thinking that because they're supporting the narrative, they will be backed up in the future. No, you're going to be thrown under the bus. You are better off trying to answer the question and saying there is no evidence of, but not doing anything. You're setting yourself up for the future.
Yeah, I think so, Philip. And I think this has to do with the way the medical fraternity is practiced. Uh, you never tell a patient there's nothing wrong with you. You always tell a patient, I don't know what's wrong with you. At the end of the day, the patient that presents to me know there's something wrong. I can't tell him there's nothing wrong. I got to figure out what ails him. And whether it is medical or whether it is spiritual, there's something wrong with him. And I got to accept that. Now, with the medical fraternity, when I look around me, Philip, they're all scratching their heads trying to figure out what's going on. But nobody seems to want to take the time to look at relearning, re understanding what has actually transpired. Uh, it's if I had to put it into a nutshell, I'll say uh, it's the lack of childish ignorance that has brought on a lot of arrogance and ego that has clouded people to the true extent of their ignorance. And so they refuse to learn. They think they know everything. And times have changed. Pathophysiology has changed. I think we need to understand that our ignorance is actually going to result in our downfall. And it's going to result in the more than I have spread misinformation. It's the ignorance of the medical fraternity that is going to lead to the eventual downfall of that fraternity.
Yeah, I think that as I'd said before we started live, is that I got tired of people telling me that um, my concerns about the future trajectory of illness is not relevant because there have been so many studies showing that vaccination save lives and there is no issue going forward. And yes, there are a few people who had negative consequences either from infection or vaccination, but it's not significant. And it's because of that frustration why I went and got the data and got this outline showing the trajectory of disease. And I'm going to show something to the audience, and I'm going to ask you your thoughts about this in relation specifically to the liver. Okay. And truthfully, this is something I didn't notice until 20 minutes ago when we were looking at it. So, as the audience, take a look at this here. What I've got here is a breakdown of the hospital admissions by age group. Okay. 0 to 17, 18 to 29, 30 to 44, all the way up. When you look at this one here, 0 to 17, one of the top things that's rising is fibrosis and cirrhosis of the liver, almost 100% rise, toxic liver disease. This seems to be the top in this age group. But what I then noticed is when I look at the 18 to 29, toxic liver disease again is number two. And I didn't realize this before. 97% rise. 30 to 34, hypertension is top, but again, toxic liver disease, 134% increase. Again, 40 to 45 to 59, toxic liver disease, 137% increase. When you look at 60 to 74 years old, toxic liver disease, 171%. And finally, over 75s, although myocarditis is top, toxic liver disease, 156% increase. So across every single age group, this seems to be one of the most consistent risers in terms of hospital admission causes. What in the world do you think could be going on?
Philip, I've seen quite a few patients where they've had liver pathology with no other pathology. Their liver seemed to have been targeted. One of the patients that I've seen, they did a CT scan and found spots of necrosis, tiny little spots of necrosis throughout the liver. I had a patient who flew down from the UK who's been having raised liver enzymes with no other symptoms for the past 2.5 years with no treatment for it. So in all patients, Philip, there are three areas that we treat: the immune dysregulation, the microvascular clotting and its consequences, and of course, the dysregulation in the gut microbiome that causes a lot of the persistence that we see. Now, if the gut symptoms are overwhelming, blood that's absorbed from your intestine first has to pass through your liver to detox. So it shows a high toxic load that the liver is dealing with from the gut itself. Look, with all patients, I question about their gut habit, their bowel habits, and if I find anything untoward, I put them on an antibiotic, kill all those bacteria I'm suspicious of, purge them, and restart the microbiome in their gut, and I get good benefit from that. But the gut, I think, is a slow burning fire that people are unaware of. It's smoldering away, and you think you're well, but the core, your gut, is never completely settled. So the liver would be the first port of call for any toxicity manifesting in the gut. As well, uh, patients develop leaky gut, a whole range of other gut pathologies, and that puts a strain on the liver because it's got to detox all those molecules that shouldn't have been absorbed in the first place. Uh, with the liver pathology, there's always also a subset that show microvascular clotting that seems to affect the liver. So I'm not sure whether we're having this kind of immune process in the liver, toxicity, immune dysregulation, triggering microvascular clotting. The liver is also a filter, Philip. So if the microvascular clots are being formed by immune complexes that are being absorbed or in the bloodstream from blood that's being absorbed through the gut, the liver will be the first port of call that those microvascular clots will go and plug in. It's a filter. And so I'm just trying to figure out where the pathology lies, where the triggers are, so that we can
You know,
negate some of this pathology.
as you said, because I'm thinking, as I told you before, we're doing a bit of research looking exactly at this question as whether or not this is an immune complex disease. And I'll share with you a thought that I had. I've been talking about this COVID storm where you have the spike trigger person gets infected again and they just get quite sick, sometimes weeks afterwards. And I recently was doing a presentation about an unusual case. And one of the doctors said something to me after the presentation that really struck me. And this was, I was talking about a patient who had heart and brain and skin and very unusual presentation. And the person then said they saw this pattern when they were working in pediatrics, multisystemic inflammatory syndrome, MISC.
Yeah.
And as they said it, a light bulb went off in my head. And I thought, oh my goodness, what we have transitioned from is in the first phase of the pandemic was severe respiratory COVID. Where we are now, it's an inflammatory systemic response that can affect multiple organs at the same time. And we have no idea what the mechanism was for children. And therefore, we can have no idea what the mechanism is for adults because MISC also affected adults. It was just pretty rare. But children tend to get it. So then Suppose adults are now getting this in a far more significant way. How would we know?
You wouldn't, Philip. If we don't have the right investigations, we're never going to figure it out. And what complicates things, Phillips, if I look at the patients that I see, they present very uniquely, but uh, the uniqueness of their presentation is carried through to the next infection. So those patients that when they get COVID tend to gravitate towards certain pathology, lung or sinus or neuropathy or reemergence of some old injury pain. We treat it, we resolve it, but the next time they're exposed to spike protein, they trigger the same kind of symptoms. So it's important for each patient to recognize their unique presentation so that they're aware that this is an immune dysregulation caused by spike protein. So whenever I have a patient with a prolonged illness, yes, I treat it, but I also educate them about the nature of that illness and ask them to remember the symptoms so that if they have a cold or a flu, and after a while it tends to gravitate into those kind of symptoms, it was likely an exposure to spike protein and it needs a complete different way to treat it. A lot of patients are getting retreated with antibiotics under the premise that it's a new strain or a new infection, but that's not the way to treat it. It's not a new infection. It's just an immune dysregulation that brought back a lot of the same kind of symptoms. The one thing I look for, Philip, when you have an infection and you have an immune response to it, the two overriding symptoms are a fever and generalized body aches and pains. Now, when you have the immune dysregulation, a lot of the time it is without the fever and is without the generalized body aches and pains. The pains are more specific. So when I have a patient that comes to me a week or two after the flu, those are the questions I ask. Has the fever subsided? I start looking for signs of bacterial infection. So is there a fever? Is there generalized body aches and pains? Is there purulent mucus production? If none of that is there, and there's no, remember, even with the viral infection, you will have a fever. Your body starts to fight. If there's no fever, then it's not that kind of reaction. And so then I start to gravitate to an immune response, a dysregulated immune response. And by doing that, Philip, by making sure there's no infection there that's playing a part, you can put the patient on a steroid and reset their immunity. So I
I
think you've got to
want
be very vigilant in that way.
I want to share something that I've been noticing, and you can tell me if you've seen something similar. When they present with these unusual patterns, as soon as it starts, meaning that if I can't make sense of it, the first question in the back of my mind is, okay, is this now a COVID exposure? Okay. What I find very interesting is that the patients very often don't know. The two things that I look for is I usually say, okay, 2 weeks or so before these symptoms started, did you have any other symptoms? And I say headache,
Mhm.
fatigue, not necessarily sore throat, runny nose. And what you find is that invariably they had a prodrome some weeks before that they said, yeah, I felt just really unusually tired. This was just different, but I didn't have a cold or I didn't have a
Yeah.
sore throat. And so it is so subtle, the presentation now. Is this what you are seeing as well?
Yeah. Philip, you have to, as much as we're questioning patients, trying to get as much information from them, patients tend to give us what they think is relevant. Now, to trigger this immune dysregulation, you can have a sore throat for a couple of hours and it went away. And for the rest of the week, you're feeling fine. And then suddenly the symptoms start, the dysregulation starts. With Omicron, I'm seeing a lot of patients present with the onset of the illness being a headache. No fever, no body generalized symptoms, just an unusual headache. And the next day, it's a sore throat and symptoms start. A lot of the patients now with these variants presenting with gut symptoms as well. So in that scenario, Philip, every patient that presents to me gets educated that look, you got to watch. Every patient gets told that I expect a daily improvement and a complete recovery in a reasonable space of time. Anything new, anything unusual, anything worsening, I must know immediately. And anything lingering after a week should never be ignored, even if it's just fatigue. I found, Philip, fatigue is the one overwhelming symptom in patients that are developing microvascular clotting.
You know, as you were speaking there, something else popped into my head. Are we almost dealing with an adult version of rheumatic fever? Okay. So in rheumatic fever, it's a bacterial infection that triggers the immune response that then leads to either the carditis or the joint and so on. But what's interesting in those children is that when they get exposed, sometimes they don't even know the exposure and they get either the carditis flare up or the joint flare up and so on. And you have to leave them on antibiotics until they are in their 20s and they're beyond that risk period. Do you think that we are dealing with people who are at risk? Even the slightest exposure can reactivate that immune dysregulation again, and we may need to think of longer term strategies to manage them.
Yes, most definitely, Philip. If you have a propensity to react, that propensity will be there. You're never going to get rid of that. So, context: if you're allergic to a bee sting, it doesn't take 100 bees to kill you. You just need one. But the guy who's not allergic can tolerate 100 bee stings. He's not going to die from it. So I think each person has a propensity to react. And that's why I think it's very important for individuals to understand that risk. When you talk of rheumatic fever, the illness might be insignificant. That's the bee sting. But even with an insignificant illness, if you have the propensity to react immunologically inappropriately, you're going to. And that can have disastrous consequences. So the initial triggering event might be of no consequence, and the patient won't remember that. But what transpires afterwards is of grave consequence. Now, like rheumatic fever, where you got very specific target organs, in different patients, now we're sitting with a setup where there's different organs that will be targeted in different patients. And each patient must understand their unique propensity so that they recognize it quickly and we can stem it quickly. So that, Philip, if you leave this immune dysregulation for a long time, like in children, where you have this multi-system inflammatory syndrome, in adults, when you have a dysregulated immunity for a prolonged period, you go through an immune reconstitution inflammatory syndrome. Your immunity tries to reconstitute itself, ignoring all the things, the pre programming it had through your childhood exposures, and tries to reset itself to cope with what's transpiring right now. Now, in that reset, it takes its hand off certain other things that it was doing for a long time. And so you'll see the opportunistic infections and the cancers and all the other problems that you'd see. Those problems don't come directly after the vaccine. It takes a while for your immunity to get exhausted with doing what it's trying to do. And when it starts to go through that exhaustion, it starts to reconstitute itself and relook at how it's going to distribute its forces throughout the body. So it pulls some away from things that it thinks are not of grave consequence because it's dealing with this big fight where you got the spike protein exposure. And those doors are left unguarded. And so we're seeing the turbo cancers and the opportunistic infections and all those kind of things flaring up. So, yeah,
As as you said that, I went and I flicked this up here again. This is the again this is the oncology part. Again, skin malignancy going up. This here is now myeloid leukemia. This is going up. This one here is uterine cancer, significant rise. Lung didn't went down, I guess, because so many people with lung cancer died, but it's still going back up again. Hodgkin's lymphoma rising. This is eye and adnexal cancer. So you can see across the board, um, breast cancer is about flat. And I'm trying to see if anyone decreased. Endocrine gland neoplasm uncertain. It's up and down. So you can see that this is not just random in the sense that when you say that, people used to be criticize that, no, that's not true. Well, I've got the data now. The data clearly indicates something has changed. As to
Yeah.
why it has changed, again, we can speculate, but we still have no detailed research to support, these mechanisms. There is so much work to be done, and my worry is that the medical fraternity is cornering themselves by not asking the difficult questions. When did medicine become no longer able to advocate? It used to be a fearful profession for politicians and so on. They would rip into them if they did anything that was outside. When did this change?
Philip, it's a sad state of affairs that we actually face. Medicine's supposed to be about the patient, about doing everything in the patient's best interest. Today, it's run by pharma, it's run by regulatory authorities, it's run through politics, and so doctors' hands have been tied. If you look at research, we're talking about the lack of research in this direction. It is not for the lack of direction. We've been talking for the last 5 years, and any researcher worth his salt would have went and looked. But unfortunately, the research goes in directions that the people that are in charge of the propaganda will finance it in. So it's not for lack of direction, it's not for lack of questions that need to be answered. It's just that no one's willing to go look for those answers. And the medical fraternity and research community, scientific community, should be looking for answers. That's our job, to try and figure out what we don't know and go and look in that direction. So I think that's one big failure, that we haven't listened to the questions, and like curious children, go look for the solutions to those, or look at why. I can't understand why that innocent curiosity isn't there. I think it shows that there's a lack of innocence. There's propaganda. There's an agenda. Anyone innocent would look at something and be curious about it and go want to look. The research community has been tied with their hands behind their back, and they can't go look, even though they know where to go. So that's one big issue. The second is with the medical fraternity itself. The biggest advances in medical science always came through collaboration with doctors, not with pharmaceutical companies, not with new drugs, not with new innovation. It came with doctors discussing what they saw and getting each other's experienced input to try new things. So we met in the doctor's lounge at the end of the day and discussed our difficult cases, and everyone gave their 2 cents as to what might be the possibilities. And like we discussed, Philip, it always sparked some bright ideas. And you go back tomorrow and try it with the patient, and there it worked. And then we go research that and take it forward. Now we've lost that. Doctors no more collaborate in that way. With the litigious society that we live in, everyone's in their own little silo, doing their own thing, and doesn't want to share information with each other. And so that's gone. From medical science, that collaborative understanding of the human body is gone. Now we look at pharma, and we look at regulatory authorities, and we look at professors in universities who haven't seen patients to tell us where to go and what to do. And that's basically, we've lost the trust and faith of patients, because we're looking to a third party to tell us what to do when we should be the first port of call in their protection.
I feel that we may be saved by artificial intelligence, because I can no longer trust that the system will do the right thing. But artificial intelligence itself needs to be protected from being trained on a narrative. And that's a huge challenge in itself. But we need to get back to very objective science. And now, one of the things I'm going to share with you again, something else that I thought was very concerning. And again, you can tell me if this is what you see. Across the board, one of the conditions that is rising is hypertensive heart disease. It's just primary central hypertension, hypertension and renal disease is just going through the roof. I'm finding that patients' blood pressure is getting dysregulated when they have had recent exposure. That's where they have the headache and they have the fatigue 2 weeks before. Their blood pressure will go out of control, and then they will have some kind of event. And this is what triggers them coming to the hospital. But in my view, this should be a really important public health kind of
Yeah.
message to the public to say, listen, if you think you've been recently unwell, make sure to check your blood pressure. And if your blood pressure is up, go to see your doctor so that he can make sure that you are being treated and you monitor it. Because what's interesting is I find that the blood pressure issue tends to kind of resolve in about 6 to 8 weeks, meaning that it's not a permanent change. It's like, again, an immune kind of response that causes a risk, a transient risk that can be managed. Any thoughts on that?
Yeah, Philip, I see the same, an increase in hypertension. But what I'm noticing is that patients that were never hypertensive before, that present with raised blood pressures, there's no reason to immediately put them onto medication to try and control that blood pressure, because what I'm noticing is that patients have very fluctuant pressures. It's normal, and then suddenly it's sky high, and then a few days later it's back down to normal. I've had a lot of patients who've seen specialists being put onto antihypertensives and had hypotensive crises. Suddenly the pressure dropped too low. Now, why would that be a fluctuation that way? We've never had that kind of thing with hypertension before, which shows that the hypertension is not the primary problem. There's an underlying problem triggering the fluctuation in blood pressure. And when I look at what those possibilities would be, the two things that I see that cause this fluctuant blood pressure, one is microvascular clotting. And if you have an ischemic area in your body, if you get a clot stuck in your fingertip, you won't feel it, but you'll have ischemia in the distal part of that. That would cause a feedback loop to put your pressure up to make sure that blood flows to that area. So you'd have a patient with an elevated blood pressure, but it is an essential kind of hypertension. When that clot moves through the capillary and is no more occluding that capillary, then of course the blood pressure will return back to normal. And if you put them on any medication while it's high, that medication was not warranted and it'll make the pressure go too low. So it's to look at microvascular clots. A lot of patients that have this problem with blood pressure, when I put them on a combination of aspirin or colchicine, or if it's severe, onto rivaroxaban and address their microvascular clots, the blood pressure stabilizes. Of course, the second part of it is the autonomous dysregulation, vagal tone, all those kind of things play a part in it. So if you look at that side of things, you got to look at in those patients, is there some kind of nerve dysregulation? But the treatment tends to be about the same. You can get the same benefit with using the same modality. And so, yeah, I tend to get good results in treating those kind of things. But it shows that what we knew as the markers for illness have changed. There's something underlying and influencing those markers. So you can't just look at a patient's pressure and try and treat that. Ain't gonna
One
work.
of the interesting things I found as well, and this would fit with what you said with the vagal, is that sometimes you put them on a calcium channel blocker or a ACE inhibitor. It doesn't really um, work that well. But if you use a beta blocker,
Yeah,
suddenly their blood pressure, and that straight away can indicate, okay, so this is more to do
yeah.
with sympathetic parasympathetic drive and so on. This is some complex stuff, Shankar. How in the world are we going to figure this out if doctors are not talking? They don't even seem to be interested.
Philip, at the end of the day, there are billions around the world that are vaccinated, and we waiting for the victims of this war we fought to fall. The shots have been fired. So you're not going to be able to ignore this. You're going to become obsolete if you're not looking into this. Look, in South Africa, Philip, I see things changing. There are a lot more doctors asking questions because they're realizing that they have no benefit to their patients, and so they got to understand what's transpired. I've had a few doctors come along with their patients to consult with me so that they could learn. I'm happy with that initiative that they're taking. We've already had a conference here in South Africa. sanctioned through the medical council, where I presented my work and educated doctors on how to treat the pathophysiology, all that kind of thing. And so, yeah, there's a subset of doctors starting up. We're also seeing mainstream specialists, oncologists, that are using alternate ways to treat these cancers that they're seeing, the turbo cancers, because I think they've realized their hands are tied, chemo's not working. We've never seen cancer spread in this way. And of course, we're seeing benefits with alternate treatments. So now they're starting to look in that direction. So I guess when your ego gets challenged by your ignorance, then somewhere you will decide to try and reestablish your ego by going and learning something new and figuring it out. The problem is, Philip, that the spike protein affects the body in such a variety of ways that it is a complete it's a complete change in the way you see the patient. So it's not just a matter of relearning one simple thing. It's a complete step back and relook at how pathology presents itself in this new environment.
Yeah, it is certainly very challenging. I mean, the complexity of patients these days, I have to say to younger doctors regularly, I have to say, you may not know this, but patients never used to be this complicated. You know,
Yeah,
you'd have one or two,
yeah,
but yeah, but
not what we're seeing.
not every week or every month you're seeing
Yeah,
like, oh
yeah.
my God.
Now it's every day, and it's almost every second patient. My practice numbers have dropped off simply because my consultation time has moved from 15 minutes to almost an hour, because you're seeing all these complex cases, and you gotta spend your time with the patient to try and figure it out. And so, Philip, talking about medical students, we have a major issue. If the future of medicine stands any chance of being relevant, the information that we have in treating patients should be put into a course and be taught in medical school, so that these doctors come out prepared for what they're going to see. They are wholly unprepared for what they're going to meet when they come out of medical school, because they didn't get the training. And because we are considered fringe misinformers, the information that we've gathered, which is so vital in negating all the mortality and morbidity, is being suppressed. And that, from the way I see it, that's the most important thing in actually solving the problem. Philip, it's crazy. I get patients traveling from the UK, from Australia to South Africa to come and see me. I mean, along the way, you couldn't find a decent doctor that understands what's going on. Now, is this what medical care is going to become? That patients, well, if this is what doctors want it to be, I guess that's where it's going to go. That a few doctors who've carried the can understand how to treat this, and they're the only ones that are going to be getting some good results. And so patients are going to gravitate towards them. And it's going to be a large cohort of patients, Philip, that are going to need this kind of help. So when I say doctors are going to become irrelevant if they don't take the time to understand what's going on, that's going to happen. And it's going to happen very quickly and very suddenly.
So here is a hard question for you, Shankar. Just imagine that you had just gone along with the narrative and you'd followed along, taken all the general principles, and then suddenly you think, oh boy, you know, all right, I may need to readjust and understand. Where in the world would you start at this point?
Philip, if I was younger, I'd go back and relearn everything that I needed to relearn to make myself relevant. At the age I'm in, if I did what you said I did and I refused to actually understand what's going on, I think I would retire in embarrassment.
Well, I mean, the point I'm making is that this is so complicated.
Yeah.
This is 6 years of, I'm just thinking, we've been talking and looking at this for over 6 years. You can't condense that easily into a course, into a CPD. It is extremely difficult. And I think the challenge is going to be, and I think this is what you have started this, in that you are starting to give doctors insight and train them. um when I use an analogy, when you started putting cannulas into patients, how long did it take you to become an expert at putting in a cannula where you would probably rarely miss a vein?
Yeah.
And so when you think of that, how long does it take for somebody to get that kind of experience and expertise to understand this transition in medicine?
Philip, I think it's the way that it's presented to the doctors and how they can take away from it. Remember, the 5 to 6 years that you spend in medical school gaining all that knowledge, every bit of knowledge that you're gaining in medical school, every system that you taught about is influenced by spike protein. So it's a brush that should permeate 6 years of medical school. Otherwise, you're going to come out wholly ill equipped to deal with the population you have to deal with. So that's the first important thing, that we need to get it into medical school and make this mainstream. It influences the entirety of physiology. Secondly, when it comes to doctors learning, we understand it's a broad diversity of systems affected. And with doctors that haven't sat with their textbook for years, that can seem like a daunting task to open a textbook and go through everything again and start to understand new knowledge. But taking a page out of what I've done previously, when I first trained doctors in Malaysia for treating COVID, I could see that they were pretty concerned about trying it, scared. Of course, there was the narrative that created more fear. But what I actually did, Philip, was every person, every doctor that actually trained under me, we put them onto a WhatsApp group so that they could have mentorship going forward. And they could, even those that didn't understand, could put their cases on there and get opinions from other doctors. We started our doctors' lounge again using WhatsApp so that all the doctors could converse with each other. I stood back and let everyone else give information. I made sure that doctors that helped each other were doing the right thing. It was only when they got stuck that I would pipe in and say, give them direction. But that created a hope. There was a lack of fear. And within the first 2 or 3 patients that you treated and saw the benefit, you were galvanized to do it again. So I think the fear was overcome by the excitement of seeing a patient recover eventually. And that's what galvanized doctors to actually take this and move forward with it. So I think the excitement of being a doctor has been captured by regulatory authorities and big pharma, and we're not allowed as doctors with the scientific inquisition to go and explore out of sheer curiosity and wanting to benefit the patient. Now we have to follow rules and regulations and protocols and not meant to think outside the box. I can't see why I spent 6 years in medical school if I was going to throw away all that knowledge and follow a protocol written by some regulatory authorities in bed with big pharma. Where's the point?
Yeah, so I mean, this is, as I said, quite a big challenge because based on what I am seeing and based on the research looking at pathophysiology, we are just at the cusp of a whole shift in disease manifestation for the next decade. And if we are unable, as a medical profession, unable to understand it, it will come at a serious cost to trust in medicine and, of course, to patients themselves in terms of their longer term outcomes. As we close out, Shankara, I want you to think about where where should be the next step, because we're seeing that the voices that were asking questions and seem to be getting more attention, suddenly it feels as though there is a shift again to silence everything and to just move on. I don't think that there is an ability to move on because the implications are so stark. What are your final thoughts with regards to the future?
Philip, I think it might look bleak. Uh, we can't move on because the patient in front of me can't move on. He knows he's unwell. And we, as providers of healthcare, we need to update our knowledge to be of assistance to all these patients. I think the medical fraternity is on the verge of a complete rewrite. There are disgruntled doctors, seeing what's happened. And I think at the end of the day, it's those of us that are willing to buck the system and be rebels for the benefit of patients that are going to actually rewrite the way medical care is instituted over the next few decades. So I think we literally, Philip, at a point where there's big changes coming with humanity spiritually, and I think that there's going to be a lot of destruction, but also rebirth. And I think the rebirth will be on principles that are different: no more money and power, but more collaboration and love and compassion. And that will form the basis for the next golden age of society. So I think there's hope. But yeah, there's going to be a lot of fracturing. There's going to be a lot of pain. There's going to be a lot of darkness. And so, yeah, if you want to avoid it, I think the innocence of being a child and trying to learn and do your best in society is where we need to be. What's going on around us, I think, is a big distraction, a huge distraction.
Yes, yes, yes. And I know we need to keep talking more, Shankar, because I think those clinical insights are so very valuable for the public and even clinicians if they're listening to hear, because it means that there are tools that are available. And so we appreciate those insights, Shankara, and we look forward to talking to you again in the near future. So thank you everyone for staying with us. We appreciate all the people who are here from all over the world, and we look forward to bringing you more information in the near future. Thanks again, Shankara, and just stay with me for the outro.
Thank you, Philip. Thank you.